We must demand that women's health is protected, funded, and prioritized because women's health matters to all of us.
We need people from all walks of life to stand up for women's health research because when we invest in women's health, the benefits ripple across families, communities, and generations.
When we design medicine for only half of the population, we fail everyone. But when we design it for everyone, we can transform the future of health.
This is not a niche topic. This is not a niche market. This is health in general. Women's health is everyone's health.
What our scientists are uncovering right now are things that medicine never knew before.
And women's health is really, it's really the gem to be uncovered in this time.
Let's share data. Let's be part of collaborative research platforms. Let's not move only at the speed of our own organization. Let's join these collective efforts.
The data is clear, the opportunity is massive, and the time to act is now. Good afternoon. I'm Carolee Lee, the founder of WHAM, a not-for-profit dedicated to accelerating research and investment in the health of women. And I'm delighted to welcome you to what I believe will be an important and a very timely conversation. Let's start with some astounding data. 82%. That is how much higher cancer incidence rates are now in women under 50 compared to men, up from 51% in 2002. This is not an isolated one disease case. Diagnoses are rising across multiple cancers, including breast, colorectal, uterine, pancreatic, gastric, thyroid, and lung cancers. One projection estimates a 30% global increase in early onset cancers by 2030. This is not one disease. This is a pattern. And it continues to focus us on the critical questions about biology, risk, detection, and the research gaps that still exist across women's health. There's so many ways in which early detection could fundamentally reshape cancer outcomes for women, and it has the potential to change so much, and so efficiently and quickly. So let's focus for a moment on breast cancer, where nearly 50% of women have dense breast tissue, which both increases cancer risk and makes tumors harder to detect. More than 1/3 of cancers are missed by mammography in women with dense breasts. And in lung cancer, the number one cause of cancer death in women, 5-year survival rates rise dramatically when the disease is caught early. Yet because symptoms often do not appear until cancer is advanced, only about 28% of cases are detected at an early stage. And this, of course, is true with other cancers. That's one of the opportunities in front of us. And the implications are not only ethical, they're economic. A recent analysis from the University of Michigan estimated that cancer screening has saved the US at least $6.5 trillion over the past 25 years. Earlier detection does not just save lives, it reduces the need for complex late-stage interventions. It lowers healthcare costs, and it creates the possibility for better outcomes at scale. That makes this not only a medical imperative, but one of the most significant opportunities in healthcare today. Somehow this moment feels different. And I think for the first time, technology might be catching up to the scale of the problem. New technologies, AI, advanced imaging, and emerging approaches to risk prediction are not just improving detection for women, they have the potential to fundamentally change how we identify risk, how early we intervene, and how we think about prevention itself. I wish we had all afternoon to explore the many different types of cancer and how symptoms are often missed in women, and I assure you we'll do this in the fall. But today, I'm eager just to begin the discussion to explore how emerging innovations could reshape prevention and early detection, why earlier identification matters more than ever, and what this breakthrough moment could mean for the future of women's health. At WHAM, we focus on one core idea. When you invest in the health of women, you unlock insights that benefit everyone, while also addressing one of the most undervalued opportunities in healthcare. WHAM was launched by creating reports built on a foundation of vigorous data and the massive economic opportunity for investing in women's health research and companies, and by convening leaders across academia, medicine, industry, and innovation, and investment to help accelerate change. Through our reports, our campaigns, our research awards, and our collaboratives, we work to advance the data, the science, and the cross-sector partnerships needed to close gaps in research, to drive innovation, and to improve outcomes for women, not in 30 years, but in the next 3. We know there are still many unanswered questions. Why are cancers rising in younger women? What signals are we still missing? How do hormones, life stage transitions, and sex-based biology shape risk differently in women? And how do we build smarter, earlier, and more precise pathways to detection? And to explore these important questions with us today, we are incredibly fortunate to be joined by several leaders who have helped shape the field of early detection, from breast imaging and point-of-care technologies to pioneering work in lung cancer screening and AI-driven innovation, as well as an extraordinary biopharma leader and champion for better detection for women. Thank you all for being here, and let's begin. So with that, Susan, I'd love to turn to you as co-founder of Curing Women's Cancer, being on the faculty at Johns Hopkins Center for Bioengineering, Innovation, and Design, and as faculty emeritus at the Johns Hopkins School of Medicine, Department of Radiology. You are such a leader in breast imaging and women's health, whose work spans clinical care, research, and the advancement of new approaches to earlier detection. And you've spent over 30 years on the front lines of breast imaging, shaping how we detect and diagnose cancer across your clinical, academic, and industry experience. And now your work of advancing point-of-care solutions is amazing. What you have learned about where early detection is falling short right now is really something that where we are consistently missing opportunities to diagnose cancer sooner, is really something I'd love for you to address, and anything else that you would like to share with us today.
Well, thank you, Carolee. I'm honored to be here today. And I want to thank Carolee, the entire WHAM staff. And I also want to thank the audience for being here, right? We're raising awareness. And I am looking forward to learning from both Sheila and Claudia today. They're experts, and there's so much we can learn together. Carolee has explained a bit of my path. I was in academic medicine. The last half of my 30 years at Hopkins, I transitioned to Hologic, so I've worked in industry, and most recently I've co-founded Curing Women's Cancer, which is a 501c3. At Hopkins, I had a front row seat to something that was very exciting, but also very frustrating. We were making extraordinary advances in AI-assisted early detection, rapid molecular diagnostics that could be used at point of care, and point of care treatment for breast cancer. But we were doing this within a centralized care system that most women in the world will never access. We're also swimming upstream in the US. The healthcare network in the US is focused, it's an economy, it's focused on profits, from devices to patient care. And I kept thinking and asking, what if we could leapfrog this? Well, in 2019, I got an answer. It wasn't an easy answer. I was diagnosed with stage 4 lung cancer. I had brain mets. I had double vision. So my career in breast imaging was over. But what really stopped me wasn't about my career. It was the recognition that I was alive. I am alive today only because I live near Johns Hopkins and I have a world-renowned oncologist taking care of me. What about the women who don't? And this is the reality that drives what I do. 1,800 women die every day around the world from breast cancer. Many of those deaths are preventable. And as Carolee has already said, behind those women, their families, economies, communities, and we're not individuals, we're cornerstones. So at CWC, we built a care model that's different. We built it at point of care where women live, work, and raise their families. And the heart of our model is point of care ultrasound with AI. We have 3 steps, 1 visit. And we can do this without a hospital, a referral chain, and a second appointment that in many cases absolutely never takes place. We have a roadmap. It's 5 to 7 years, $31 million. That's a lot of money. I am fundraising. I am very aware. It is a lot of money. But what we're looking for is proof of concept, evidence validation, providing training to mid-level providers that's sustainable, and also ultimately influencing policy. And our goal is to reach the 2.5 billion, that's billion with a B, women in the world who have no access to breast cancer care. Our goal is to save 1,000 lives a day. That number should stop us all in our tracks. It's exactly why CWC is moving forward. And each of us in our own way have an opportunity to break down the inequities that exist. So let's all get together, join us. Let's do this together. We will be more effective as a team. And thank you again for including me in this important discussion.
Well, Susan, you know how important you are to me on so many levels. And I am so appreciative of the personal story because it is the personalization that is going to bring this hour to life and brings us all to life. In order to connect you with Sheila, I want to turn next to Sheila, who is a dear friend and a member of our WHAM board. And we've just had such a great time in partnering together in building WHAM. Sheila has also built a number of, as an extraordinary entrepreneur, a number of biotech companies. She is a biotech leader. And more importantly, what I've watched and witnessed is how she's become a women's health advocate who has helped build and scale groundbreaking life science companies. But at the same time, she's become an incredibly powerful voice, both in advocacy for improving breast cancer screening and early detection for women with dense breasts. So Sheila, Susan, I'm going to ask you if you'd like to share a little bit of your own experience with breast cancer screening and the actions that you took as a result, the outcomes that you're now working towards to ensure, as Susan is, that women are diagnosed earlier.
Well, Carolee, first of all, thank you so much for hosting this. I think it's so important to tell women about the need for early detection and the role of screening in making sure you can find your breast cancer when it's still curable. I do want to give a shout out, though, to Susan. My heart, I think, just was so happy to hear about your mission and your goals. 1,000 women per week is unbelievable. And if I can help in any way, I'd be more than willing to do so. It's just an astounding thing that you're doing, Susan. My own story goes back to 2022, a few months after I had gotten a clean mammogram. I was getting out of the shower and I noticed a small dimple in my left breast. I had just turned 56, so my first thought was cellulite. You know, everything was sort of sagging more than it used to. So I thought, well, this is just part of aging. But I talked to my daughter, and my daughter said, Mom, you should really, get it checked out. I was always told that I was unlikely to get breast cancer. I don't smoke, I don't drink, I exercise. I'm sort of the epitome of good health. But I went in and I had a diagnostic mammogram on both sides of my breast. And on the left-hand side, they saw something, but it was clear that the diagnostic mammogram had a hard time depicting anything. So they went in and did an ultrasound, and they came back and said, I need a biopsy. The biopsy came back about a week later, and it was a slow-growing, large tumor, almost 3 centimeters. So when I sat down with the oncologist, I said, well, clearly the mammogram missed this. And how do you know I don't have breast cancer on the right-hand side? There was no reason for me to think that I had breast cancer. My breast cancer actually had no lumps. Uh, but my breasts always felt like a bag of marbles, right? And so when I compared my left and my right breast, I was like, well, my right breast feels the same as my left. So how do you know I don't have breast cancer on the right-hand side? And I got a lot of pushback. First of all, bilateral breast cancer is very unlikely. And second of all, I was told it would cost me $1,300 to get access to a breast MRI. Luckily, I had the $1,300. So I, basically whipped out my Visa card, got access to a breast MRI. And it was fortunate that I could pay for that because the results came back and I had a larger tumor on my right-hand side. And so I started really asking a lot of questions, right? I work in drug development. I don't know a lot about imaging, MRI, CT scans, PET. I really didn't, know what I needed for my breast cancer. I was always told that the appropriate imaging for my heterogeneously dense tissue was the 3D mammograms, digital breast tomosynthesis. And I've learned since then that that's probably not right. You really need more than just a mammogram, a digital breast tomosynthesis. And I'm sorry to say I was so naive. I thought it was something extra, but it really is just the baseline mammogram. And so if you have dense tissue, you need to have additional screening, either an ultrasound or even better yet, there's now many studies done showing that a breast MRI finds more breast cancers than any other modality. And so since my experience, I have been trying to do two things. One, to educate women on the need for additional imaging if they have dense tissue. And second, I'm trying to make sure that every woman, regardless of their financial position, can get access to that additional imaging. I have introduced in the state of North Carolina for 6 years a bill with Susan G. Komen and the American Cancer Society to provide coverage, insurance coverage for that supplemental imaging. And for 6 years, we have battled and we haven't been able to pass it, which is really amazing to me how much resistance there is. Because like Carol Lee said at the beginning of this whole session, it is cost effective to pay for the additional screening because if you find cancer earlier, not only does a woman have a better chance of actually getting it cured, but in addition, it's a lot cheaper to treat earlier stage breast cancers than later stage breast cancers. It's just common sense. And so, as Carol Lee mentioned, that's made me into a fierce advocate. I go to Congress and trying to get the Find It Early Act passed, which would ensure that women across the U.S. Get access to the additional imaging they need. And then also my home state of North Carolina, trying to get state bills passed. So thank you again, Carol Lee.
Oh my goodness. Listen, thank you for all that you're doing and for the fierce advocate that you have become, because without you and other women like you, these bills don't get passed. And I think there was the first woman who had a similar experience, I think it was from the state of Connecticut a number of years ago, and also took it upon herself to lobby to have a bill passed for the coverage of additional screening. Before I turn to Claudia, Susan, I'd love to hear your reaction in terms of, or some reaction, in terms of, I always find some confusion around, okay, so exactly what am I supposed to do? I have dense breasts. Tell me which test to have. So do I need an MRI or is it sufficient just to have an ultrasound and the mammogram? And then just we'll get off on AI and all of this, but if you want to just respond a little bit to that I think is helpful.
Well, thank you. And what you're describing is what every woman who walks down this pathway encounters. And often the guidelines will say something like, talk to your primary care provider. Well, your primary care provider is busy fighting hypertension, diabetes, obesity, all the other cancer screenings. And it is an unfair expectation that they will have expertise, detailed expertise in each of those areas. So exactly what Sheila has described is the pathway that should be followed. If you have dense breast tissue, and Carolee, as you pointed out, about half of the women in the world do. So this is really common. Mammographic sensitivity is between 30 and 50%. Adding on that ultrasound, we know from multiple studies over multiple years, increases cancer detection rates from 3 to 7 per thousand. That's more than doubling the cancer detection rate from mammography alone. It is incredibly helpful. But as Sheila has said, breast MRI is the most accurate tool we know of. It is overly sensitive, so there are false alarms that take place, but it's the most accurate tool for people who are facing decisions about treatment. The challenges Sheila has already discussed. The cost, can you afford it? It is very expensive and very state to state, as well as access. In Baltimore, I think on the Hopkins downtown East Baltimore campus, we had, I don't know, making the number up, something like 40 MRs. But if you're in North Dakota, if you're in the rural South, you may have to drive hours and hours to reach an MR. So it's a quagmire of knowing and getting proper information and then getting access. We're not very good at describing all of this. Why is there not a website, right? Maybe we should do that. But all this to say, Sheila, thankfully you made it through the pathway in exactly the steps that I would recommend and others would recommend.
Yeah. If I wanted an MRI, Susan, and my doctor says, well, it's not covered by insurance, where do I go?
Yeah, it's a good question. You can approach your insurance provider. And my personal experience with my healthcare is that often things, the first answer is no. United Healthcare, 30% of the claims that come in for them, they say no to. So again, this is advocacy and standing up and saying, hold on here a minute. Here are the risk factors. Here's how I meet the requirements. And unfortunately, that takes a lot of energy and a lot of time. And you're often put on hold for literally hours. But that is the approach. Will your doctor help? Maybe. Will Claude or ChatGPT help? They can write an awfully good letter for you. So there are ways around this, but it's complex and so many women miss out. And I'm speaking from a place of knowledge, right?
Yeah, that's scary.
It is scary. And so there are ways around, but they're not straightforward.
Well, we'll come back to that because I know that a lot of people are curious about that. Let me just turn now to Dr. Claudia Henschke, who I've had the pleasure of knowing now for a number of years. And if you're not familiar with her work, you're going to become familiar with it because it is seminal in terms of not only lung cancer, but I think the ability now to extend that, as I said earlier, perhaps to diagnosing other diseases as well. But I'll let her explain that. She is a professor of diagnostic, molecular, and interventional radiology at the Icahn School of Medicine at Mount Sinai and known as a pioneer in lung cancer screening. But I think if you read at all about Claudia, you get to know her. Her work has transformed how we think about early detection through the advancement of low-dose CT screening and global research collaboration, which I'll also let her talk a little bit about. But lung cancer, as we know, Claudia, is the number one, or not everyone knows, is the number one cause of cancer death in women, more than ovarian, cervical, and breast cancer combined, which is a data point that I did not know until probably later in my life. But your mission really to achieve early diagnosis, treatment, and the ultimate cure of lung cancer has had a profound effect on us all. So I'm going to let you talk a little bit about how your work has come about and how you're detecting lung cancer earlier.
Well, thank you. First of all, Carolee, it's wonderful that you organize this, and Susan and Sheila's comments were really very wonderful. And what they call for is collaboration among between different screenings. So let me just back off and say how we started. We started saying that we can detect lung cancer early back in 1992, a long time ago. It's taken a long slog, as they say, to get to where we are now. But we said that if you find it early, you can cure it much more easily. And it's amazing how hard that concept was to get across for lung cancer. People didn't really believe it because many of the studies that had been done were negative. So also important to understand is that women are at twice the risk of equally aged and equally smoking men. And most people don't understand that because they always hear smoking and think about men smoking. But really, women, whether they're smokers or never smokers, they are twice the risk of equally aged and equally smoking men. So screening for lung cancer is really important. And actually, we also report on dense breast. What you said is that um, their synergies. So we see dense breast. We report them on every CT scan when we see them, so that the women understand that they need to get other imaging modalities for breast cancer. But moving back to where we did a study that of 1,000 people. It took us 8 years to recruit those 1,000 people at two institutions, NYU and Cornell at that time. And we showed that you can find lung cancer early. And that was an astounding, that caused a lot of people to rethink their attitude about lung cancer. And it took much longer, of course. In 2006, we talked about that we can cure 80% of lung cancers if they're found early. In fact, 80% of all the cancers that you find in lung cancer screening, whether they're late or early. And people didn't believe that. We now reported last year or 2 years ago, we reported again that the long-term 20-year follow-up provides more than 80% cure rate compared to normally a dismal 5 or 10% without when screening is not used. So, but amazingly, in that intervening from 1992 to today, it's been a slow start to get lung cancer screening moving forward, and that people really understand that they should ask for it. Um, it's our work led to two randomized trials that all showed lung cancer screening is safe and effective and reduces deaths from lung cancer. The National Lung Screening Trial in the US and the Nelson trial in Europe. So it's been confirmed. But despite that, there's the many more people are now covered by insurance, but they don't use lung cancer screening. And lung cancer screening really should become is a simple CT scan that takes seconds, a single breath hold. You get the CT scan at low dose, low radiation, and you see not only the lung cancer if you have it, but you look at coronary artery disease. You can see emphysema. You can see dense breasts as we have. So we now think about it's comprehensive screening that allows you to look at all of the organs that you're imaging in that chest CT scan and help make better decisions. We can, for example, when we do a CT scan and we look at your coronary artery calcifications, we can say that 20 years from now, this is your risk of dying of coronary artery disease. And we can individualize that risk so that you can take strategies for decreasing the risk of lung cancer. The same thing for emphysema. So we're entering a age of preventive, really using all of the tools that we have, each imaging device, for comprehensive health decision making and improving deaths from lung cancer as well as heart disease, emphysema, and we do see breast cancer. We look for each and every very carefully at the breast because there's some hidden areas where mammograms are not so good, where MRI may be better or CT may be better. So there really should be a lot of synergy between the different screening disciplines.
Yeah, but Claudia, may I interrupt for a moment? I mean, I probably have better care than most people. No one has offered me lung cancer screening.
Well, the problem is that at the moment, the rules are now in the U.S. for if you're 50 and older and have at least a 20-pack year history and you can't be over 87 or 86 years of age. And we don't agree with that. We provide screening under an IRB, under a research protocol for women and men 40 and over, whether they are smokers or never smokers, and we have no upper age limit because if you get lung cancer at 86 or 87, you can still have a wonderful, healthy life if you treat it, and you can live to 100 or more, and the average lifespan is much older. But at the moment, it's very restricted, and they require a shared decision making. So it's complicated to get a CT screening even if you qualify. And if you don't qualify and want to have it, you have to find a place that performs it for you, and you might have to pay for that. We've tried to reduce the cost of a CT screening to $200, but because normally a CT scan costs much more.
So Claudia, look, I've got a million questions, and I know everyone does, but I have to segue to AI because I know that
okay.
Obviously it's going to revolutionize healthcare, and you've been deploying it, for the very long lung cancer screening program that you and your team have. And I know that you published an article, I think recently in January, it led to the creation of an AI-enabled automated image reading system, AIRS, to detect, measure, and characterize lung nodules. Can you talk a little bit about your use of AI and how you feel this will basically upend, but in a good way, your research and improve not only the diagnosis, but any other findings that we're going to be able to get from it?
So my degrees were actually before medicine were in mathematics, statistics, and computing. So I've been looking for that AI for quite a few years, and slowly now it's become all the techniques are becoming more available. So when you do a CT scan, you can really automatically read that CT scan. No scan is approved by FDA, so that you have to read it with a radiologist. So but that's becoming very, very useful. We also say when you come back year after year, because you have to do the low dose CT screening on an annual basis for lung cancer to really find it early enough to be effective. And most of those CT scans are unchanged. So the AIRS project is that we will fully automate the comparison of a CT scan with a prior CT scan and say, is there any change? And if not, then hopefully we can get approval that the radiology doesn't have to read it, and then they can focus on the more difficult CT scans. So that really makes screening much more available because radiologists are in short supply, and chest radiologists reading a CT scan for lung cancer is tedious. You have to document all the little nodules, and that can be very time consuming, and you can get tired and make mistakes. So this will help once we get FDA approvals for these various AI techniques. It'll expand markedly the availability of of lung cancer screening, not only in the U.S. but also in the rest of the world, where radiologists are even harder to find. So
Claudia,
this,
sorry.
go ahead.
Yeah, I'm sorry. Can I ask you what's the risk of what's the risk of radiation from these CT scans versus
So
obviously?
it's the radiation dose of a low dose CT scan is that of a mammogram. The dose is getting even lower than a chest X-ray. So the advances that are being made are tremendous. So that in the future, CT scans will be maybe at 1/3 of a chest X-ray, which is phenomenal.
Yeah, I think your work, and I remember from lunch you telling me about all the years that you spent as a mathematician. So that was not wasted on me. I remember that, and it was at that time. That was like I think several years ago. I don't think AI was kind of where it is today. So let me come
Oh,
back to
but
that.
we were always working. In
Yeah.
fact, I contacted maybe 20 years ago, I contacted the military and I said, you must be using AI to, it wasn't called AI at that, called neural nets, but you must be using that to look for tanks. And can we apply it to lung cancer, to CT scans? And they said, oh, we still use people. But then the advances in the computers and in the computing technology has now really led to an explosion. So it's going to continue to increase and make all of this even more available.
Yeah. Yeah, for sure. Thank you. Let me skip back to Susan. Just while we're on each of you using AI, I'm kind of curious in terms of, I know the recommendation is that we have one screening for everything, but that's not happening yet. So, Susan, talk to us a little bit about AI has been used, I know, for quite a while in mammography, and it's not replacing the radiologist. The radiologists still obviously are reading or tell me that they are mammograms. But how has it helped you as a former radiologist? What is your inclination right now in terms of where this is going?
Thank you, Carolee. And I just want to make a comment. Claudia, I worked at the Johns Hopkins Applied Physics Lab, which is primarily a DoD shop, Department of Defense. And we have pivoted a Department of Defense targeting activity into breast imaging. So what you started continues. So thank you. In terms of artificial intelligence in breast imaging, as you point out, there's mammographic AI, and there's ultrasound AI, and there are components of MRI that are called AI, and what they have to do with is blood flow, which is a major diagnostic tool. In mammography, there is ample evidence of great success when those AI models are applied to the test set of the training model they were trained on. Right? When you put those out in the wild in a population that they essentially haven't seen before, they still work, but they're not as accurate as those reader studies suggest. What most of these models do show is that there is an increase in accuracy, most prominent for general radiologists who are interpreting breast imaging. The folks who have done breast imaging fellowships and are focused on breast cancer may get a little boost, but much less. So this is really valuable because when we look at the United States, 80% roughly of all the breast interpretation is done by general radiologists. And the variability is tremendous. We simply let that fly in the US. There are other countries that do remediation testing and training. So this AI gives us at least a standard that is a reasonable level of skill. The ultrasound AI is less robust. And for the most part, they don't look at the whole ultrasound image. So the mammography ones look at the entire mammogram and then they supply decision support. In ultrasound, which is a real-time opportunity, it's only decision support. What those AI tools have shown is an increase in specificity, meaning there are fewer false positives. That is incredibly helpful. Most of the cost of mammographic screening, a screening program, is in waste. Those things that happen that ultimately turn out to be benign. And so as we can get that under control, we're also beginning to control costs. So the AI tools that exist are effective. They can be improved. There's no question. And what we were working on with the Applied Physics Lab is one of those areas. More things are coming along. Computing power is growing. And so we have a lot of opportunity to advance AI in imaging, which is very, very different from Chat GPT and Claude, right? This is a different animal.
For
Thank
sure.
you.
You bring up a very important point because the AI, people say, oh, you can apply it anywhere. It's very, as the equipment gets better, the AI will not do as well unless it's retrained. And so the training is key. Really the understanding of the radiologists that use it, the limitations are important to understand. So your work is very important.
Yeah, no, but both of you, all of you. And let me just flip quickly, Sheila, because I know that Susan alluded to this. In many European countries, screening protocols are often include a follow-up ultrasound or MRI. What is preventing the US from adopting a more comprehensive standard of care? Because I know this is something that you have delved into and feel passionately about.
Insurance companies.
Yeah.
It's that simple.
In a nutshell, right?
In a nutshell, it's unfortunate, but here in the US, insurance companies dictate the standard of care and not, scientific evidence, which is very problematic. It's all about cost benefit, but it's not cost benefit for the patients, cost benefit for the insurance company's profits. It's very frustrating. And, in breast cancer, I looked at the economics. There was actually, Medicaid had done a study in the state of North Carolina. Medicaid in our state covers additional breast cancer screening beyond a mammogram. And they do so because they determined it was, cost effective to pay a few $100s for an ultrasound, or even $1,000 or $1,200, $1,300 for a breast MRI because of the cost savings associated with finding cancers earlier. The treatment cost goes up significantly between a stage 2 and a stage 3. Just think about it. If you have a double mastectomy, it's a pretty comprehensive surgical plan plus reconstruction, multiple rounds of chemo, multiple rounds of radiation. It's a lot easier to treat cancer when it's small and contained in the breast. I took that logic to the state employees' healthcare plan, and we were able to convince the treasurer of the state of North Carolina to adopt expanded insurance coverage under the state plan for state employees. So now in our state, the only group that doesn't get covered is, people on private insurance. And I think the reason for that is they're hoping that we age out and we're on Medicare. It's the only logical conclusion that I can come to. But the problem is more of us are getting breast cancer at earlier ages. We're not going to age out. We're going to die before we get on Medicare. But unfortunately, it really does seem like the value of individuals is not high in our country. It's all about making money. And I don't mean to be too cynical, but the hospitals, I feel too, make more money if a woman is diagnosed later. I was definitely pushed down a path of double mastectomy reconstruction. Luckily, I went to, it's important to get multiple opinions. I went to a place where they were able to take out the tumors out of both breasts. And I just had to have radiation. They did a test looking at the likelihood of distant reoccurrence, and mine was pretty low, so I didn't even need chemo. But my first treatment plan was very aggressive. And would have cost well in excess of a few hundred $1,000. At the end of the day, with the double lumpectomy, my treatment costs were about $30,000, a big difference. And unfortunately, breast cancer treatment is one of the highest, it is not one of, it is the highest costing cancer treatment. The burden on women is much higher than any other type of cancer. And often, women have to bear a portion of these costs and they end up, in financial difficulty. So I don't know. I think the European system, it's basically a contained healthcare plan. It's a national healthcare plan, and they have an incentive to make sure that the costs are contained, and that means early detection. And I don't mean to make people so depressed or sad. I just think you have to be aware of the reality that you're dealing with. Otherwise, you can find yourself in a situation that is worse than it needs to be.
So, go ahead, Claudia.
For lung cancer screening, really, the U.S. has taken a much more proactive by providing for Medicare and Medicaid coverage, whereas Europe is still not doing, has no national, there's only one country, Croatia, that has a national screening program in Europe, and now they're slowly starting, but they're way behind. So each of the medical systems has the pros and cons for various diseases, but I agree with you, it's the finances that really are distressing.
Very. And I guess, for all of you, why do early detection solutions for women struggle to scale even when we know the science and technology exists, particularly like in areas like dense breast tissue where mammography alone is often insufficient and supplemental screening is yet still not widely adopted? It's basically the same thing, right?
I think a piece of it, having met with both government and private payers trying to get things approved, a piece of it is women flip in and out, women flip in and out of insurance if you change your job, there's so much change that what they are concerned about, let's say, is the quarter, not the 3 to 5 year outlook and cost. So that's the impression I've had. Sheila and Claudia may have more extensive experience, but short-term gain is valued over longer-term survival.
Yes, yeah.
So then let me ask, Claudia, what in your opinion then would it take to shift from reactive detection to truly proactive risk-based screening, specifically for women, given all the data that we know that non-smoking women are twice as likely to be affected by lung cancer as non-smoking white men, et cetera, et cetera. Why is it that we're unable to get this changed?
I don't know, but women are better at getting legislation or anything through, or even coming through the screenings. Women are much more proactive for the screening. So getting the word out to them is the key, and that will help the whole family for various diseases.
Do you see in the very near future that we're going to have basically one test for all of these diseases? Because right now I'm not getting all of these different tests, but am I going to be able to walk into your clinic or Mount Sinai and get all of these tests done in one screening, all of these different modalities?
No, the mammogram is exquisitely sensitive to that, and the CT scan is very good, but it's not going to do the same as a mammogram. And so I think there'll be more than one, and for colon cancer, the same thing. So you do need different tests for screening, but you can maximize the information you get from each of the tests. So from the CT scan, we learn a lot about the whole chest. And you want to maximize that and really provide that information and make sure that the person getting the screening understands. That's the other thing. The CT reports that we give, or the imaging reports, now can be translated with AI into much more user-friendly terminology. And we really need, so it's the education that goes along with each of these imaging tests that we give to the person getting it, not just to the doctor who refers it. So it's a lot of education, a lot of work, and women are good at doing that. So
So keep it up.
it's important to get the word out to the
Yeah. So, we've been so intrigued by the work that our partner at Northwell Health, Stacey Rosen, and others are doing in terms of the calcification of breast tissue, I believe, that can show early detection of heart disease. So there are, obviously, we're all becoming more aware of the overlap between these different.
Lori Margulies, we did the initial, we did that together because and amazingly, the pushback was that people said, no, women don't want to know from their mammogram about coronary artery disease. And so we did a survey. We had to do a survey to get that accepted, that we could say something to them. Amazing.
Good for you. Thank you for doing that. Sheila, let me flip back to you. Looking ahead, we love 3 years, not 30, as you know. If we could make one change in the next 3 years that would meaningfully improve detection, early detection for women, what would it be?
Yeah, I think educating women about the need for supplemental screening, I think that's the key so they can advocate for themselves. The supplemental screening rates are still only about 10% for women with dense tissue. So that means that 90% of women that should be getting a second step aren't getting it. And so if we tell women that they need it, then at least they can, when they visit with their doctor, they can advocate to make sure that they are getting either an ultrasound or a breast MRI. And, women, okay, maybe insurance won't cover it. There is, there are a lot of changes now with the guidelines changing and really being very clear that women with dense tissue need supplemental screening. The only guideline still that is problematic is the U.S. Preventive Services Task Force guideline. But most other guidelines are really telling women that they need this additional screening. So I think insurance will change. But regardless, women, should have the right to determine if they want to buy a plasma TV or if they want to get the additional screening.
Absolutely. Claudia, I'll ask you the same question. With your magic ball wand, crystal ball is pretty good because of your background. What is it, and maybe not so much the change that you're making or that could be made in the next 3 years, but with AI and the work that you're doing, what is it that you see happening that will meaningfully improve or change how the early detection and therefore the improvement of managing any kind of disease?
Well, it's really the education and also the physician and it's hard for radiologists really to spend a lot of time talking to the patient. So it's education not only of the referring physicians, but it's education of the individual getting the screen. And I think with AI we could tailor the report or give additional reports, and we just need to think about how to make that work better, because that's the best way to reach, I think, to reach the person who's getting the screening and to provide the information for what they can do for the rest of their family is also very important.
Yeah, for sure. Yeah, thank you. Susan, I started out this session by really talking about the impact of younger women being affected by cancer, rising cancer rates. And that is happening, obviously, as we know now, across the board. We don't know exactly why. But with the rising rates of cancer in younger women, what is it that you would recommend that women do if they fall outside of the standard screening pathways? Because that seems to be the biggest issue, right? And education, I hear very loud and clear, is a part of it. But do you have another thought on this?
So my experience working globally is that the biggest gap is access, and it gets even larger when women are younger. So mammography has radiation. So there are realistic limits placed on that because it is believed, based on modeling, that younger breast tissue is more at risk when there's radiation exposure. So in my mind, that suggests let's think about what other technologies, what else is available to reach these younger women. So hands down, it's education of those younger women, but it's also thinking of let's take this to point of care where women are. Young women think they're too young to have breast cancer. The providers they go to say, oh, come on, that lump is nothing. You're too young for breast cancer, and they get dismissed. And so having an option that is where they live, and that can be in their primary care provider's office, that accounts for what they're feeling and noticing in their breasts. Sheila's given us a great example, skin changes, and it turned out to be huge. There are other opportunities, but I think point of care and using ultrasound. We're currently running studies looking at portable ultrasound devices with AI and comparing those to mammography. And we're doing that in sub-Saharan Africa and in Washington, D.C. This information is critical for moving forward. But in women that are less than 40, you don't even really need the comparison, right? We've got to offer something different for these women and educate both the women and the providers. Don't dismiss this.
Yeah, thank you. Well, look, clearly I could talk to the three of you all afternoon, probably into the evening. And I really offer you my deepest thanks, not only for your insight, obviously for your leadership, your audacity, and to all of you joining us today for this very important and very obviously very timely conversation. So I'd also like to recognize our partners and collaborators whose support makes this work possible. This is a short list, not a complete one. And following today's discussion, we always share a recording with anyone who registered. So thank you for being part of the effort to accelerate research, to accelerate investment and innovation in women's health, and of course for supporting WHAM. As you've heard me say before, meaningful change does not happen by chance. Look at the people in front of you. It happens when people come together to shape what comes next. And if today's conversation resonated with you, we hope you'll consider supporting WHAM's work. That would mean the world to us. Your support helps advance the research, the data, and the cross-sector collaboration needed that we can drive better outcomes for women through education, through programs like this, and accelerate the progress in years, not decades. I believe that together we have an opportunity to help turn today's insights into real-world impact. You've heard it from each of these leaders. I thank them immensely for the work that they do, and I thank all of you for being with us today.